We're going to talk about information and communication technology today, and we're going to talk about it in a space that involves healthcare and construction, but in a space that may not be as familiar and comfortable for us. So let's start by kind of getting out of that comfort zone. When you think about technology on a hospital construction project, let's shift past design and think about the load, the lift, the requirement for the IT department to actually implement, integrate, and get a hospital open to take care of patients. Currently, that default approach that we're all familiar with is construction teams acquire technology design firms. That's a mature process. It's mostly effective. It still works. And IT departments depend on that expertise. It's expertise that doesn't live in a hospital IT department. And that's not going to be going away. But what we're here to talk about today is the components of the work that the hospital IT department is responsible for, and the implementation of those technologies, the integration of those technologies, and even the ongoing support for those items. Think about what it was like to walk into a hospital in the 90s. When you walked into the hospital, medical equipment items did not ride any kind of IT network, and in fact were in large part standalone, certainly didn't integrate with any IT systems, right? Wireless networks in the 90s? Not that frequent, right? You walk into the hospital, you'd see PCs and printers in administration offices, business offices, one at the unit secretary on the floors where patients get taken care of, printers, right? Phones everywhere, right? But that was kind of the look and feel, right down to the picture of the PC with the floppy disk that we've seen. That's what it looked like in the 1990s. Even the nurse call systems. Back then we had these dry connect, very simplistic nurse call systems where when I was a floor nurse in the 90s, we used to joke around that we might be better off with 2 long strings and a tin can, because we ended up walking down the corridors a lot, looking above the patient rooms for the light and listening to where the alarm was. A lot of unnecessary, a lot of added steps, inefficient, not really great for the patient either, waiting for people to come by and help out. But that's what it was like in the 90s. Very straightforward, very unsophisticated, absolutely doable from an IT department perspective, right? 100% doable. And the technology design firm Shake with the IT department Shake was very straightforward and very doable. But, and you knew that there was going to be a but, right? In the early 2000s, despite the benefits that electronic healthcare records, or EHRs, could bring to healthcare, there was a lot of resistance. And so there were programs like ARA, the American Recovery and Reinvestment Act, and Meaningful Use in 2009. It's important, it's not just stuff. Those created incentives, big incentives for hospitals to go through the procurement, go through the cost, and go through the pain of implementing an EHR, looking forward to, 1, meeting those regulatory requirements, but 2, the potential to deliver care to patients with less errors and in a more meaningful way. Fast forward to 2015, 96% of hospitals had a certified EHR. Only in 2015. It's not that long ago. So if you think about 2015 to today, roughly a decade, that's a massive shift in technology for what you walk into a hospital and see today. One thing to note with the EHR is when we're designing space and we're thinking about clinical workload, we used to have a very big emphasis on physical devices, and we still do, but it's important to know that most of the workflow that exists, especially for clinicians today, is built in and lives in applications and software. less in that tangible, physically built space and the devices that are there today. And this is important to understand. Not one department in a hospital, not one goes without some specific support, some application to support that department's operations and to guide their work. Not one. We think about the EHR, it's very important. Patient care is now reliant on the EHR to some degree. A patient will not get a medication, they won't get a meal tray without the technologies that the IT department installs, integrates, and supports. In addition to the EHR, it's important to know now, with that technology evolution, hospitals have and support hundreds of applications in addition to the EHR, and in addition to the clinical spaces that we always think about, like ED, OR, lab, pharmacy. Those are kind of given. They have their own special software and applications that support theirs. But what about the gift shop? What about nutritional services? What about transport, the guy that comes to take you from your patient room down to X-ray? All of those things, to include supply chain systems, payroll systems, HR systems, billing, and accounts receivable systems. The hospital can only provide services providing they can stay in business. All of those applications, all of those are reliant on IT to implement and to provide for the new hospital. All of those applications, the same way you physically build the rooms, there are virtual builds in applications, just like your physical build. And all of those applications require a look. Most will require rebuilding, retesting, recreating the integration that allows that application to talk with a variety of others, retraining and redeploying those applications. And as I said, in addition to the clinical areas, a lot of the workflow now, because we know there are PCs everywhere now, nurses actually get one assigned to them in some cases every time they turn up for the shift. That workflow for those different departments lives in built-in applications. The difference between the 90s and to where we're at today, it's a different world, is it not? And thankfully so, in my opinion. You remember the nurse call scenario that we talked about in the 90s? Now, the patient can select what type of help they need from their bed. That trigger will still put the alarm and a light on outside the patient room, but it also will ring into the pocket on a wireless telephony device that the nurse and nurse's assistant carry around, and then they can pick up the phone and talk to the person who just engaged the nurse call and save a lot of steps, because maybe I can stop at the med room and pick up medications on the way to his room. And it also allows nurses to work higher on their scope of expertise, the top of their license, which is a huge satisfier, because if the patient pushed that they need help maybe to the bathroom, that's going to ring to the mobile telephony device in the nurse assistant's pocket. She can also, hello, Mr. Patient, what can I do for you? And she can go right to the room after letting him or her know that help is on the way. I could stand here and talk about a lot of technologies that you are all familiar with, real-time locating systems, any kind of system that drives an elite patient experience, like the ability to open your blinds, control your room temperature, or to control your lights. These are standard vanilla type integrations and functionalities that have been around for quite some time now. What's important to think about today is two things: technology convergence, right? This is the situation where now medical equipment items not only ride an IT network, and IT has to have the expertise to provide that. You can get alarms from those physiological monitoring devices on the same wireless telephony device that the nurse carries around if the patient's alarming outside a predefined range, right? Now, wireless networks are everywhere. 3, 4 of them minimum, because all of them do different things. And that technology convergence to where refrigerators write a network and the tracking and automation happens now. That's technology convergence, right? Where medical equipment, fridges, bone freezers, you name it. All of those things, in addition to the application that the different departments use to guide their work, all of those other items are necessary, and they also require sharing information to other systems. That's technology convergence. Didn't cause that to happen. None of us can stop that from happening. That is our world on a go-forward basis, technology convergence. Another thing that hospital IT departments and hospital executives talk a lot about these days are emerging technologies. You've heard of it. You can't turn the radio on in the morning without hearing about AI, digitization, you name it. Healthcare executives are relying in large part on technologies to help solve for critical problems that they have, whether it's staffing, shortages, burnout, just operational inefficiencies. Hospital execs are counting on these emerging technologies to help them bridge gaps. The other important thing to know about these emerging technologies is that, as important as we all are, these are things that are actively being prioritized and planned for as part of their portfolio today. There will be a time where we don't get out of having to implement these things in newly hospitals we create, right? So emerging technologies, and that includes things that we can't even think about today, that will be in place and probably a rote sort of implementation at some point. So we've covered a lot of ground, a few decades, and now, knowing from the 1990s to where we're at in the 2000s to where we're at today, that lift for the IT department got significantly heavier. And it's growing in sophistication. And so the people who implement those things and support those things have to mirror those sort of expertise. So, but now we have a baseline, right? Now we have an understanding, a joint understanding of the sort of evolution and technology and what to expect in hospitals. Here is what we all know to be most hospital construction teams consist of these D-flat players, right? You know them. We have the architect. They have specialized expertise and understanding of construction and tools to help them in their work. We have general contractors, same thing, expertise, tools like Procore to help them with planning, guiding, tracking progress for their work. PDC departments, dependent on their makeup and their size, will oftentimes procure external expert support in the form of owners' representatives. They also have expertise in construction and tools to guide their work. Administration and clinical benefit from an expert external resource with knowledge in construction and tools for that work. The clinical engineering and supply chain management get external support from medical equipment planners who have construction understanding and knowledge of tools that support their work, like freight train, right? These are the default players. Despite the massive technology shift from the 1990s to today, IT departments and construction teams still approach post-design IT in the exact same way as the 1990s. So if you're feeling occasional pain where IT is concerned, or it's getting more and more untenable, that might be why. I loved the difference between invention and innovation. Innovation, making improvements, and gradually, like Kaizen, making things better. But we're here to talk about innovative ideas and solutions. And so with that, if we recognize that a lot of the other areas, arguably with less reach into the hospital, have external support areas and specialized tools. We advocate for shifting away from that same approach, even though we're familiar with it and it's comfortable for us. Shift away from that approach we used in the 1990s and adopt a modern approach, an approach that brings the necessary support through the use of an ICT resource. Right? An ICT resource to bridge that gap and to help IT be a better teammate to construction on these projects. Quickly, let's dive into a real-world example. This is a 1 million square foot hospital replacement project, $1.5 billion budget, level 1 trauma center that consisted of a university affiliation that should click a added complexity button. It had an adult tower and a pediatric tower. And this particular project utilized the approach that we're advocating for an ICT resource for the post-design implementation work, the support for the IT department. That approach for this particular project created some unique and innovative synchronies, and the synergy was paramount. The ICT resource was onboarded at the same time as the technology design firm. The ICT resource can estimate the true technology budget for the project. Here's a hint. Applications, IT applications, integration, and IT resources do not get, budgets for those areas don't get developed from a per square foot equation. They're budgeted for differently. And the ICT resource also is able to estimate the IT department resources by team, by hour for the duration of the project, which helps IT know when resources are going to be needed and have them reserved for this very important project. This project happened, I mentioned, in California, so the HCI, for those of you who've done work in California, the HCI, formerly OSHPD, impacts, you already know what that means. This happened in the middle of COVID. I mean dead in the middle of COVID. The IT department was trying to perform the resources necessary to build this hospital, but they were also supporting tents being built in the parking lot for extended COVID care. They were supporting telehealth. They were supporting drive-through testing clinics, vaccine, just everything. And through the use of ICT resource, despite those challenges, the IT department was able to deliver the technology components on time and on budget. I get asked every now and then, why are we still doing it? Why, though? Then why? Why are we still doing it that way? The thing that I think is that the power of the familiar is strong. We all know the people that say, I love change. Yeah, and I love change makers, but our species doesn't really do all that well when push comes to shove with change, right? And hospital IT departments and hospital executives don't know what they don't know. They count on construction teams, owners' reps, to guide and navigate them through the construction process and to recognize when different players need to be added to better support the whole needs of the overall construction project and make it to where you can actually open the doors and take care of patients someday. So, in conclusion, instead of relying on the hospital IT department with unreasonable and arguably unfair asks, especially more unfair asks as we go forward, especially on projects that are so large, risky, and foreign, the healthcare margin for error is shrinking. It has to be done right the first time. We advocate this new approach to technology. Let's move healthcare IT construction into modernity, into the 2025. The technology partnership model we discussed should become the standard. It's a holistic approach that covers the needs, and it recognizes IT as an integral part of the project past design. A strategy or a design is only as good as our ability to execute or implement, right? And so embrace the spirit of collaboration and innovation and effectiveness, and join us in making a modern approach to IT on these projects, the only approach to IT on these projects.